Part 2 of this day's session, the cervical spine musculoskeletal disorders. In the part 1, we saw the cervicogenic headache, the clinical pattern recognition, and the outline of the manual therapy plan of interventions. We are going to begin now with the part 2 for the cervical spondylosis. Cervical spondylosis initially was felt as age-related disorder. But most important, nowadays it is being present even in younger individuals, mainly because of poor posture. Okay. So you have a situation where the cervical spine is abused or overused, leading to premature aging of the tissues of the cervical spine. It begins with the dehydration, loss of the water content, and it continues as degeneration, where the tissue integrity is altered, collagen fiber transition happens, the tensile collagen is replaced with the compressive collagen. The compressive collagen which is there in the cartilaginous end plate or in the articular cartilage is replaced with tensile collagen. So the whole properties and the response to the mechanical forces gets altered. That leads to the minimal trauma within the joint, leading to the body's response to produce more and more synovial fluid. So the initial phases of degeneration will have effusion, and because there is an effusion, too much of fluid collection, there will be an instability, excessive motion, because joint space is increased. So in the acute stage, there will be joint space will be increased. And the next one, this hypermobility will lead to abnormal contact points in the joint, which will lead to further and further degeneration. And as the degeneration more and more it progresses, the damage across the articular surface or the subchondral bone will lead to formation of new bone, which is called as the osteophytes. In the intervertebral disc area, after the cartilaginous end plate erosion, the uncovertebral joint is there laterally. So they also go for erosion. Then they project and they form new bones, which is called as syndesmophytes. In facet joints, zygapophyseal joints, they are called as the osteophytes. They are typical synovial joints, but the intervertebral disc is enchondrosis, fibrocartilaginous joints. Okay. Here you see the picture that the osteophytes come. They might initially, before this, the cartilage degeneration can create a loose bodies, fragments which are circulating inside the joint, which can lead to locking of the joint, which can manifest as soft crepitus. Once the osteophytes or the syndesmophytes come, then they manifest as coarse crepitus or hard crepitus, which is audible. Disc degenerations, it is called as the degenerative disc disease. Facet joint degeneration is called as the osteoarthritis of the spine. In between, if there is a degeneration of the pars intra-articularis, it is called as spondylolysis, which may be a precursor for the anterior slipping of the one vertebra over the lower vertebra. In that situation, it will be a degenerative spondylolisthesis. Okay, so you have a picture like this. The spondylosis is not just affecting the disc space narrowing that is found in X-ray. No. Okay, so it can affect multiple tissues, and when the degeneration progresses, it can affect the posterior longitudinal ligament, attachment of the posterior longitudinal ligament, attachment of the annulus fibrosus. Those areas can get degenerated, and the nucleus pulposus can come out of the annulus fibrosus. Degenerated disc, there is not much water, but still it can still herniate outside the annulus fibrosus. Okay. So you must be clear that even in spondylosis you might have a disc prolapse. Okay. And the next side, think about Yeah, pardon the interruption. Okay, it's a minimal interruption. It's a pleasant interruption. Okay, most avoided interruption. Okay, so now what we see is the disc degeneration and the osteoarthritis. Okay, both the presentations together with spondylolysis. So you have degeneration of the spine. How does it clinically present? So as I mentioned earlier that it's not just the elderly, even in young individuals. Most earliest sign what does a patient report is early morning stiffness. Morning when the patient wakes up, the neck is very stiff, especially rotations, and after 15-20 minutes when they start moving upper limb and thorax, okay, then the neck becomes a little bit loosened up like a warm up, and the early morning stiffness that eases with movements will characteristically point the spondylosis. Okay. So it can happen with the flexion extension, then degenerative disc disease, with rotations or lateral flexions, which is associated with the cracking sound, okay, in the morning. You might suspect the facet joints. Okay. So the next part, this degeneration can affect the canal. Okay, it can affect the central canal or the foramen, syndesmophytes from anterior and the osteophytes from posterior. All of them can surround the nerve root. Okay, that will lead to the foraminal stenosis. In cervical it's very rare, in lumbar it's more common, okay, foraminal stenosis, radiculopathy. But cervical radiculopathy can be caused because of this osteophytes. So spondylosis can lead to radiculopathy. And the inner side, the canal stenosis, central canal or the myelopathy can also be caused by the syndesmophytes from one side and osteophytes from the other side. So you have a spectrum of clinical presentation to identify. I had already discussed the presentation of myelopathy. I have also discussed about instabilities, okay, and then headaches also. If the spondylosis affects the upper cervical spine, very rarely it will cause the headache also. So remember, there is no situation where you will tell that there is one problem and it is the only problem, because human body, it is not just about one structure, it's not about one segment. It is multiple regions which all try to work together. So they all might be involved and one may be symptomatic, other one may be dysfunctional. So it's always important not to miss the segments and their interrelationship when you are evaluating. That's why the pathomechanics and the pathophysiological progression is very, very important. That's why localized treatments have failed to produce any kind of long-term effects in any kind of a manual therapy intervention across countries when they perform research. Okay. So always remember, treat the patient, not the tissues. Okay. So spondylosis, how are we going to approach strategically? Articular techniques for spondylosis begins with distraction, because compression reduces the disc, space, water loss, everything. So distraction will be a very, very useful technique, not the sustained distraction, intermittent distractions. Okay. We will add the compression late stages, okay, because we need the compression also for the bone strength and also for the synovial fluid. So earliest intervention is distraction mobilization, manual traction of the cervical spine, which may be combined with the Mulligan's snags. Okay, using the Mulligan belt we can give the distraction. And the next part is McKenzie's always, because the poor posture is the one which has caused the degeneration. So you can correct that with the mechanical diagnosis and therapy, or combine with muscle activations to extend it as mechanofunctional diagnosis and therapy. And later progress to combined inflection combinations. You will use the combined movements if it is for the discogenic degenerative disc disease. You will use the lateral flexion combinations or the extension combinations for the facet joint in the combined movements. Edwards concept. Thrust manipulation for mild cases of early degeneration in the end range after combined movement interventions, and attempting muscle energy techniques also, and you are not able to reduce the joint, then you can use the thrust manipulation for a locked facet. The locking should be single level locking, okay, either flexion lock or extension lock. Unilateral, young patient, no radicular pain. Okay, so then choose the criteria: medications, corticosteroids, immunosuppressants, anticoagulants. Okay, no medication, no history of this kind of medications, instabilities, all this ruled out. Then you give the thrust manipulation, and you are skilled, of course, to administer the cervical thrust. The later part, in myofascial, of course, that is the first and foremost. You can address all the myofascial tissues according to the principles that has been outlined earlier under cervicogenic headache, and also the positional release for the muscle spasm, which occurs in the early stage of effusion in a degeneration, and reciprocal inhibition also for the spasm. And after that, for the adhesions, it's the myofascial releases, and as a progression, fasciomuscular releases with muscle activity. And of course, the later part, incorporating the motor control retraining, you will involve post isometric relaxation, because there may be some kind of soft tissue adaptive shortening, so you might have to restore their length, so you will use post isometric relaxations. Once you have addressed the myofascial system, then the articular system, now you are ready to actually go into the progression of the articular system. That is by mobilizations of Maitland, where central posterior anterior pressure, which you will apply because it's the disc which you have to treat. But if you want to treat the facet joints in osteoarthritis of the spine under spondylosis, you will use unilateral posterior anterior pressures. And if you have a radiculopathy because of the spondylosis, you will use a transverse vertebral pressure from the pain-free side to the painful side. Okay, so this is my pain side, so I will apply transverse vertebral pressure from this side. So all this, and then their progressions are there. If you are giving in a neutral position, or you are giving in an extended position, okay, or you are giving in a flexed position, and then flexion with lateral flexion combinations, okay, different progressions of the positions are there, and later progressions will involve combination of multistructural arthromyoneuro manual therapy. Passive neck flexion is useful in cervical spondylosis, it's fine. After passive neck flexion, you can treat them with a slump test also. In some patients who have upper extremity symptoms, definitely you should use the upper limb neurodynamic testing and their treatments. We have upper limb neurodynamic test 1, 2, 3, 4, which can be indicated for the radiculopathy. So ULNT 1 will be for the brachial plexus, 2 is for the median nerve, 3 is for the radial, and the 4 is for the ulnar. Okay, so you can use in the distribution the symptoms, whether it is sensory symptoms or the motor symptoms which is reported by the subject, you can use accordingly. So remember not to miss this multistructural paradigm. And also, when you are talking about other type of progression, AM and MT means with mobilization force you are having a contraction and you are positioning in the neurodynamic position. Okay, so that is the late stage. And also for athletes, a tennis player who is complaining of neck pain, and he has been playing for 10 years and now he's feeling early morning stiffness, and you can suspect it's a degeneration, and then together with that there must be the disc which is maybe involved. So then you think about progression into AM and MT. Okay, so always remember the clinical pattern recognition. The model helps you to identify the disorder accurately and also to plan the manual therapy interventions based upon the pathomechanical interrelationship and the progression of the pathophysiology of the disorder. Clear? So we are through with now cervicogenic headache and the cervical spondylosis. So this section, now we will meet in the Zoom and for the practical demonstrations after a short break, 10 minutes, and we'll meet in Zoom for the practical demonstrations directly into cervicogenic headache and also the cervical spondylosis. Cervical spondylosis has a huge interrelationship with the disc prolapse, because degenerative disc prolapse, and also radiculopathy. Okay, so you know cervical spondylosis, that means you can manage many of the conditions. Earlier, all neck pain were thought like they are cervical spondylosis. Okay, so remember, like how all low back pain were thought to be arised from disc prolapse, lumbar disc prolapse. Same way cervical means spondylosis. Okay, so such a big disorder it is, but clinical spectrum will vary from patient to patient. 10 patients will come with same diagnosis, but every patient's presentation will be different. So that's why you have to individualize the therapeutic prescriptions. Okay? Good luck. Meet you on Zoom. Very beautiful Saturday morning, 20th of February 2021, day 3 of the certification course in spinal manual therapy, and the second weekend. We had the first weekend, which was physical examination, cervical spine, thoracic and the lumbar spine, distributed for the 2 days, and we had a very successful weekend last week. And then participants also received the videos in the WhatsApp, in the group that was formed, so they all would have reviewed the videos. I'm just waiting for some of the participants to join in now. And next, every opening session of every weekend, okay, I have planned that the actual inauguration of the course CSMT was also shown live on Facebook, and at the same time now again I have come live on the Facebook for this opening session. This opening session is absolutely free. It is also part of the 100 free webinars, and I was taking about cervical spine, the red flag conditions, musculoskeletal disorders, and I am continuing it with the cervical spine disorders, which are actually scheduled for today. In the CSMT, we are going to see the manual therapy for the disorders. Okay, how we are going to manually examine and we are going to manually treat people who are having these conditions. Which are the conditions? First and the foremost, the cervicogenic headache, and the next, of course, cervical spondylosis, cervical disc prolapse, and cervical radiculopathy. So the 4 major conditions, the main core of the practical demonstrations for today in manual therapy, right from day 1 and very severe irritability patients, how we handle, to the follow-up and long-term care. Okay, full plan treatment. Recognizing these disorders is based upon clinical reasoning, and we see that the Australian approach, the expert approach to manual therapy, is pattern recognition. So clinical pattern recognition. So that's the main model based upon which I am going to discuss, or I am going to highlight rather, these 4 clinical presentations and how we identify them so that we can best apply the manual therapy techniques. So we are beginning now, and this is going to be the webinar number 49 as part of the webinarathon, the century webinarathon of the Academy of Orthopedic Manual Physical Therapists. This is actually the part 2 of the CSMT, the certification in spinal manual therapy, and today we are going to see the cervical spine disorders, as I mentioned. Clear? The video, the live video, will be shared across various platforms, and utilize the time that is during the weekend so that maximum people can be benefited from this. I understand that the people who have liked this page and they are in the page are very few, and those who are now on time, okay, I have come uninformed. I informed only the participants of the CSMT course, so generally everyone is not aware that I am coming live now. Okay, so I wanted the benefit to be for the registered participants. Okay, so that's the major reason. At the same time, let the knowledge be across boundaries. Okay, so coming to the first condition, cervical or the cervicogenic headache. The terminology itself, cervicogenic, so that means the cause of the headache is cervical spine. Whenever there is a cause, or what is one region which is causing symptom in another region, it's mostly the referred pain. Localized pain means there is problem in one region and symptom is also in the same region. Okay. This referred pain, always we are all aware that there is referred pain because of joints can refer the pain. Okay, articular referred pain. Joints, I mean that bones also, capsule also, ligaments also, bursa also, synovial membrane, okay, all the tissues, even intra-articular, the articular cartilage, the fibrocartilage, intra-articular disc is there, that also, all structures including subchondral bone and even otherwise regularly the part of the bone itself, skeletal, that is also included under the articular system, which can refer the pain. They can refer by sclerotomal reference. Okay, there's a particular innervation by the spinal cord segment. So that's why hip joint pathologies we feel at the distal anterior thigh, because L2, 3, 4 is the innervation of the joint, hip joint. Okay, L2, 3, 4. So the L2, 3, 4 region, it is referred pain. Same way, if you talk about the referred pain, next one which is most commonly there is the myofascial referred pain. Pain arising from the muscles and the fascia, okay, or the tendon. So these referred pain situations are more common from the muscle in extensive injuries and also in active myofascial trigger points. So when you have an active trigger point, the referred pain will be there. If it is latent, only localized pain will be there. And remember that the joints referred pain will be reproduced on movements or on compression and distractions, okay, whereas the muscles referred pain will be reproduced by contractions and also together with the palpation. Specific locations of trigger points are there when it is myofascial trigger points, which is mostly near the motor points. So when you palpate, that referred pain will come. Of course, the third category when you are talking about the referred pain is the neural referred pain. We are aware of neural entrapment neuropathies and we have pain along the nerve. Okay? We are also aware that if there is a nerve root compression, shooting pain in the distribution of the nerve. So either pain is along the nerve or the region that is distributed or supplied by the nerve, we are having symptoms. But there is also probability that it can be a referred pain from the nerve, which may be dermatomal or non-dermatomal, but the pain will be reproduced on nerve palpation, pain will be reproduced on neurodynamic testing. Okay, so that's the neural referred pain. So anyway, you are having arthro, myo and neuro. Okay, so here we are. Cervicogenic headache. So we have a pain which is arising from the cervical spine, and you have joints of the cervical spine which can refer to the head, which is mostly the upper cervical joints. That means occiput, atlas, okay, atlanto-occipital joint, atlas and the axis, that is the atlanto-axial joints. Mostly these refer. C2, 3 can refer a bit, okay, to the head. Ligaments and capsules of all the upper cervical spine can refer the pain to the head, including the tectorial membrane, the transverse ligament, apical ligament, alar ligaments, posteriorly ligamentum nuchae, the origin, interspinous ligaments. Okay, all these ligaments can refer. Facet joint capsule of these atlantoaxial and atlanto-occipital joints also can refer the headache. Okay. The next property, if you see the structural source, myofascial, not only upper cervical muscles, even the lower cervical muscles, or even more far like even upper trapezius, which is inserted to the shoulder, okay, lateral clavicle, lateral acromion, that also can cause headache. Sternocleidomastoid, levator scapulae, erector spinae, posterior neck muscles, the suboccipital extensors, rectus capitis posterior major and minor, splenius capitis, semispinalis capitis, all these muscles, suboccipital extensors, which go for shortening and they mostly develop latent trigger points. They get activated after sustained forward bending, a poor posture, or they get activated because of contraction. Okay, this is stretching, so it is getting activated, or forwarded posture, it is contracting, always overactive, so activation of the trigger point happens. After which, when you change the position, you will get that feeling of that headache. Okay. So myofascial referred pain can come from anterior neck muscles, even scalenes can refer the headache. Also, otherwise you can see temporomandibular, the masticatory muscles also can refer to the headache. and ocular muscles, okay, eyeball the muscles, they also can refer to the headache, but they are not called as cervicogenic, okay. These are mostly the orofacial pain, okay, and the orofacial headache, okay, facial muscles or the masticatory muscles and ocular muscles, okay, if they refer the pain to the head. Major neural sources of referred pain which can cause the headache is the greater and lesser occipital nerve. If you are seeing the skull posteriorly, okay, here the greater occipital nerve will come, lesser occipital nerve will come. Okay, this is the external occipital protuberance which we palpate. Okay, and from the external occipital protuberance you are coming towards the mastoid. Okay, the mastoid process. Okay, so in this line you can see that first one third greater occipital nerve, immediately next to one finger distance lesser occipital nerve. So both the sides it's present. So when you palpate like this, perpendicular to the nerve, okay, and when you are palpating also make sure that how you confirm nerve palpation when you are there on that area, ask the subject to move the upper limb, okay, so that you are loading the other side of the nerves. So here you will find movement under your finger, okay, so that means you are on the nerve. Also Tinel sign, it might produce the headache, okay, and then next one is of course deep palpation itself will produce a local tenderness on the nerve. Referred pain from the nerve could be in any other distribution other than the area that is supplied by the greater occipital nerve. Greater occipital and lesser occipital nerve supplies only the posterior occipital region, the skin, the scalp. Okay. When you are talking about the other neural structures, the foramen magnum, okay, and the posterior margin has the dura mater. Attachment of the dura mater, the outermost meningeal layer, so that is also there. So that is the posterior dura, and here the anterior margin is the anterior dura, which is more pain sensitive. So if you are doing a neck flexion, okay, the dura mater will be getting elongated, okay. So that tensile loading on the dura mater can produce symptoms which can be pathomechanically like sustained forward bending and the subject was overusing the neck, so the dura mater got strained, and then you can reproduce it in a passive neck flexion test, okay. So remember that joints, we have seen the atlanto-occipital, atlantoaxial, their mechanics, how to evaluate them, how to screen the upper cervical spine joints, how to test the ligaments for their stability, everything in the previous session of the CSMT. Now, it is our role to recognize that cervicogenic headache can come from articular sources, can come from myofascial sources, also muscles and their differentiation together with their palpation was also demonstrated in the previous sessions. Nerves and neurodynamic testing. Okay, so you have all this to identify that the cause of the headache is from the neck. Simplest in the history, patient will identify as pain in the neck being the first presentation. Headache is now recent. Clear? The second thing, side of neck pain, side of the headache, both will be same. Mostly the headache is hemicranial, okay, half of the skull. Patient will not be having full headache. So that's again easier. So it's strictly unilateral, strictly ipsilateral to the neck pain. Never there is a side shift. The headache which is felt in the left will never be felt in the right. Okay. So there will not be side interchange unless pain is there both the sides of the neck. Okay, bilateral neck pain and bilateral headache. It's a bilateral cervicogenic headache. Okay, so that can happen. Very rare. It's absolutely very rare. Okay, so remember this. And this is the diagnostic criteria which is proposed by the International Association for Study of Pain, globally accepted and recognized as in research also, cervicogenic headache diagnosis. The final criteria, of course, you examine the cervical spine by palpation, by movement testing, okay, or you do any kind of provocative testing for the cervical spine, it will reproduce the headache. Clear? Of course, if you want to exclude the other causes of headache, plus yes, as a general medical screening, you can exclude other types by their photosensitivity, relationship with stress, relationship with systemic disorders, okay, because you have to rule out cluster, migraine and tension type headaches, okay. But what's important here is the identification of cervicogenic headache. The next part of it is also like, if a patient is telling headache, means when you palpate here, patient will tell there is no tenderness, okay. If there is tenderness only at the area of pain, you suspect it's the tension type headache, okay. The tension type headaches, occipitofrontalis muscle is there, okay, that can develop trigger points, okay. Even this masseter referred pain can come, all this, okay, these are all orofacial headaches. So remember not to miss by direct palpation. Wherever the patient is telling pain, headache is there, just palpate and see. If tenderness is there, likely to be tension type headaches. Of course, different types of migraines are there. Vascular migraines also are related to the hypertension. And otherwise, if you see the classical type of migraine, which is involved with photosensitivity, okay, generalized hypersensitivity. If the person will be allergic, okay, they will not be comfortable with different pollutants, okay, different stimuli, okay, even sensory stimuli on the face. Migraine is another disorder which is associated with the central sensitization, okay, so the patient will have pain non-anatomically everywhere in the body, okay. Next we come to the fact that when we recognize the cervicogenic headache, the cause of the headache, whether it is mechanical and mechanical disorder, what type it is. So you see for the impairments, articular, myofascial and neural. Then you plan the manual therapy interventions. We have the articular techniques of Maitland, direct mobilizations, which can be performed to the atlas or to the axis, right? And next one, Mulligan's mobilization with movements, which are performed as snags, the sustained natural upperfacial glides. So that's also given to the atlas and the axis. We have seen the landmarks where we can palpate the atlas and the axis in the previous session. When you are talking about even McKenzie's concept, the postural or the mechanical diagnosis and therapy, you can utilize for the upper cervical spine corrections, and you can advise the patient as self-correction methods. Thrust manipulations to the upper cervical spine on selective patients could be administered after the progression with combined movement testing and mobilization for the articular system in the upper cervical. Myofascial suboccipital extensors, first and foremost is the cranial base release, which is under osteopathy but also under the myofascial releases. Of course, the cranial base release can be combined with the deep cervical short flexors activation, or even the suboccipital extensors or the multifidus activation also, same side, in order to perform fasciomuscular release. Okay. So first you will prefer to do a myofascial release, later you will do the fasciomuscular release. And the next, of course, when you are talking about the progression in the myofascial one, very rarely patients will complain of spasm. Okay, they will be having spasm in the suboccipital muscles. If it is so, suspect that there is instability in the upper cervical spine, ligament laxity is there, ligament strain is there, so the muscles are trying to be in spasm. Even then, too much of spasm is producing the pain, you can do the reciprocal inhibition technique to inhibit the muscles in spasm. Clear? The next component which you will see in the muscles is of course the shortening and also the localized trigger point, latent trigger points. For the shortening, we will use the post-isometric relaxation muscle energy techniques. And next, of course, you will see for the taut band local pain, latent trigger point, you will use the ischemic compression, direct myofascial releases. Again, this direct releases also can be combined with other gross releases like head pull ear pull, hair pull, shoulder girdle releases, all are part of the myofascial release, combined with the contractions of the stabilizer muscles and also mobilizer muscles in concentric and eccentric. You are going to administer it as fasciomuscular release. Okay. So remember that it's such a beautiful way of progression. Of course, whether you will start first with the articular or with the myofascial. When there is myofascial, it is superficial. If myofascial system is not treated, you cannot access the articular system. So you have to treat the myofascial tissue first. Clear? And next, of course, you come to the neural, which is predominantly the nerve massage to the greater and the lesser occipital nerves. The passive neck flexion test, which is performed as a neurodynamic test, should be administered as a slider, and again progress to loading with muscle contraction or loading with the mobilization forces as arthro-myo-neuro manual therapy. Right? So cervicogenic headache, that is the clinical picture, the pattern recognition, the plan for the manual therapy intervention. I have added the manual therapy here because I want the CSMT participants to actually be highlighted on what are the techniques and how I am going to demonstrate on the subject. Okay. So I am going to resume the next part of this live session with the cervical spondylosis. Okay. But remember, whenever you are having flexion extension problem in the upper cervical spine, that means you are going to use the midline techniques, the central post-anterior pressure mobilization techniques. Okay. But if the patient is having problems with the lateral flexions or rotations, you are going to use unilateral techniques. Lateral flexion, you will use the side gliding, okay, lateral glides, and the rotations you will use the unilateral pressures. Okay. So always the decision making for spinal mobilization is always like this. Okay. So remember, so we are through with the cervicogenic headache. I am going to resume the next part here right in this Facebook page for the next condition, that is the cervical spondylosis.